So,
It's House Bill 2427.
I do, and I'm going to
Is there a
surprise
substitute or
Sarah
amendments to this?
here. Yes, I have a complete substitute that she does not know about. How you like that?
The chair will entertain a motion to lay this, since I don't even know. I'm kidding.
We will not.
Please just let us know. Yeah, go ahead.
I
Right, I need to
pass it around. The intent of this bill was, in the case of services, to let people know the costs ahead of time. What the substitute does, and the reason why it says Senate Bill 1004 is because this is a substitute that did pass a Senate substitute. It's Amanda Chase and I have been working together. She co-patroned my bill, I supported her. Is what this bill does is similar to the Toscano Bill Plus.
Yeah, we just gave it.
Yeah, we gave it to him.
They gave it to me, actually. The Toscano Bill Plus. So the Toscano Bill says that you have to let people know they can ask for an estimate. The plus is on the back, lines 36 to 38, that requires physician assistants, nurse practitioners to give folks a good faith estimate. Now, I'll be the first to tell you I don't think this goes far enough. My original bill didn't have the upon request. My original bill dealt with insurance. But I've been around this place long enough to know that this bill, which has the support of those folks behind me, has a chance of succeeding, whereas the original bill, which I think is the better bill, but I'm going to let it go, I didn't think had a chance of succeeding. So I think this bill does move the ball forward. I think it does allow patients to get these good faith estimates upon request. I think that's a good thing. Just because I don't think it goes far enough, I can talk with them throughout session to see where I think it can go farther. But I do think this improves current law by making clear that people have a right to good faith estimates if they ask.
All right, does everybody understand the substitute before us? Probably moved in without objection by general consensus. All right, substitute to Senate Bill, to 2427 is properly forced. Yes, ma'am, Donna.
Mr. Chairman, just because I just want to know, is good faith estimate defined anywhere to know? And the reason why I ask this is because I worked in dental insurance, and we, with the provider, we would give estimates all the time, and at the bottom we would say this is not guaranteed. But even with that statement, every time that the price was different than the paper that we gave them, there was significant issue to the tune of wanting to keep our patients, we often adjusted fees off. So I just wanted to know, what does a good faith estimate mean?
Means whatever good lawyer wants to make it sound like, you feel like.
I would answer Delegate Price that I think a good faith estimate is what a physician thinks it will probably cost. And in other words, if sometimes you get an infection, and that obviously would be an extra cost that while was foreseeable was not the usual case. So I think most doctors know the usual case for the usual knee replacement.
So
Understanding.
That's your interpretation.
That's my
So,
interpretation.
Yeah, absolutely. Delegate Robinson.
Yeah, I find this problematic because often patients will call the office and say, well, how much is my eye exam? Well, do you have insurance? What is your insurance? You can't look your insurance up unless you know what their numbers are. They have no clue what their insurance
That was
even
my original
covers.
bill.
So it's very problematic to give an estimate because you really have no clue. You don't know if they have insurance where they do have to pay and how much their copay is, unless you can really spend on one, and it's extremely time consuming and for everyone concerned. And again, along with Delegate Price, it's a crapshoot. But once you set a number, and you can give a range. I mean, you can give a range, but let me tell you, they're going to go for that low end range every time, and I'm going to hold you to it. And so it's very problematic. Whatever good faith estimate is.
So
it's a
All right,
tough thing.
hang with me, Delegate Beats.
I was just reading what Delegate Robinson was highlighting, piggybacking on Delegate Price. So in the expansion of this, because that's my favorite word, in the expansion of this existing law to the office-based setting, it talks about a good faith estimate for charges, and it's a person who's a patient. But if you look at the existing law on 12, in the hospital context, it's upon request of a patient who's scheduled to receive the procedure, or upon request of the patient's legally authorized representative. And it actually goes on to say estimate. Doesn't even have good faith estimate. So when you're expanding and piggybacking and trying to draw this together, it's not constructed properly. So, I mean, I have a problem with the way that it's written as it is.
All right.
Take out the word good faith.
You're good, Delegate Hodges.
And then my follow up on that, Mr. Chairman. So if they try to provide a good faith estimate of the healthcare services for those patients, then they go in and they have other services that need to be provided, then that can actually complicate matters as well. So I think that could really be a potential problem. I mean, if you call and, request, if, for example, could that be an issue even, with Delegate Robinson,
All right, good.
in any setting?
Any other questions of the patron?
Because I haven't answered those yet.
No, I understand. Well, they were more rhetorical than they were, I think, sort of overt questions where I think they were making comments and anything else. But let me just hear from them. I will give you the last word, so I promise I will. Anyone in the audience to speak in favor of House Bill 2427 as substituted? Yes, sir.
Mr. Chairman, I appreciate Delegate Levine hearing our concerns, and even though this was something that it was addressed in the other body, we agreed to that there and would commit to it. It's not something where we've agreed to continue to work on it. What this takes for the physicians on line 36 through 38 is you come into the office and you say, Dr. Garrett, what does this office visit cost? You, no disrespect, probably won't know, so you're gonna have to yell out to somebody at the front desk and says, what's the charge for an office visit? They say $150. And then you're gonna have to tell the patient, but if I examine you, you may need an EKG, you may need something else that, and if you wanna know the charges of those, I'm glad to tell you, but don't think it's only gonna be $150. All a provider knows is a charge. The only way you can tell a patient as to what their out-of-pocket's gonna be is a patient decides to pick up the phone and call the health plan and say, where am I on my deductible? How much is my deductible? What am I gonna be responsible for? So that's why we took this approach that we did.
So, Mr. Johnson, so I don't even read it that way. This doesn't say you have to be in their office and they have to examine you and sort of, it just says any physician who practices in an office-based setting shall provide. So somebody could call my office, I work in my office, someone call my office and say, I got groin pain, I think I might have a hernia, how much are you gonna charge?
But you're not your
Well,
patient.
they could come see, this doesn't establish that I have a physician-patient relationship with them.
Patient.
It doesn't establish that I have that physician-patient relationship with them. Someone could call my office and say, I have groin pain, I think I might have a hernia, how much do you charge? And I say I charge $200. They then expect that to be the charge. They come to my office, turns out they don't really have a hernia, they got God knows what. Now I gotta send them for CAT scans and x-rays and so on. I'm wondering whether we're actually creating true transparency for costing, which is incredibly complex, as I'm not have to tell you two guys that, versus this expectation that people are gonna be better informed about the cost of healthcare.
Mr. Chairman, you could change the word A to there, and that would solve that problem.
Am I misreading it?
I think the intent was it was gonna be your patient. It wasn't somebody just calling around doctor shopping for somebody, but if you wanna clarify that, we're certainly fine with it,
But
that
this
it's your
language,
patient.
yeah, this doesn't.
You could change the word A to there and
And
fix it.
Hang with me.
arguably, once a patient makes an appointment with you, you have a physician-patient relationship if they show up. If they just pick up the phone and call you, in the law generally, that's not enough to create a
Right.
physician-patient relationship.
All right.
Mr. Chairman, members of the committee, Dr. Rowley from the Hospital and Healthcare Association. I think we've already heard what we think about the top half of that bill. We just spoke about it earlier with Delegate Scano's bill. Just if I could, in the word estimate, I hear everything that everyone's saying, and we had this conversation a couple of years ago when the House Bill 905 passed to include that language in the first place. Estimate was carefully chosen, knowing that we don't always know exactly once you get in and open up a patient what goes on. So just that word was chosen deliberately.
All right. Anyone else in support? Yes, ma'am. Come on forward.
Yes,
Identify yourself, please.
Hi, my name's Diane Schreer. I live in Alexandria. I went to the dentist last week. This is very recent. I went in for a general cleaning. She said I needed a deeper cleaning, the hygienist. I rescheduled. I was leaving. It was awkward for me to get there, but I rescheduled it for 2 different times. And I asked her, I was like, what's the cost of this? Turns out it was over 10 times the cost that I had paid in another state 2 years earlier for it. I mean, this should have just been told up front, what the cost will be. The important thing is I was not notified about it. And it's very, very easy to tell a patient when they, this is gonna be approximately that, good faith estimate, you know that if something comes up that you don't expect, it'll be different. I mean, that's common sense, that's what an estimate means. And therefore, it is understandable that it may be more if something comes up.
Alrighty.
But an estimate gives you an approximation, and then you will know that based on insurance, it could be different, could be less.
Alrighty. Thank
Thank
you.
you.
Question of the respondent?
No.
Okay. All right, thank you very much, ma'am. Anyone else in the audience can speak in favor of, House Bill 246? Anyone in the audience?
I gotta just wrap it up, because this is the other bill I was interested in, Jill Hankin from the Poverty Law Center. I'd say this is another small step forward. To me, this bill now means that when someone asks the question, the doctor's gonna come up with an answer and an estimate. Right now, people ask the question, they say, we don't know, it's all based on your insurance and who knows what it's gonna be. Now they're gonna have to do a little bit of work to get a better response for the patient. So I think that's a step forward.
I would just ask, I definitely understand that conceptually, but what if the product that you're gonna get is not correct information, or because of all of the things that we've discussed? I do want the patient to have more information, but I want them to have information that I guess is correct.
Well, I get it, I understand your concern, but I think that the physicians and providers will have to carefully answer the question and say, what we know right now, my office visit is X, but we don't know what we'll discover. Then as we go along, you can ask questions about additional costs.
All
So
right.
it just doesn't excuse the conversation anymore.
All right, thank you very much. Anyone here in opposition to
I'm in favor of it. I'm Dr. Elizabeth Hendricks. I'm also from Alexandria, Virginia, and I don't like surprise healthcare bills on the back end. It's ridiculous, it's unjust, and we need fairness in the healthcare system. This is outrageous. We need to have an estimate of some sort, and you can have the parameters of, well, if this happens or that happens or that happens, this price will change. But we need to know on the front end what our prices are going to be, not on the back end. That's awful. Thank you.
Thank you, ma'am. All right, anyone in the audience in opposition to House Bill 2467 as substituted? All right,
Mr. Chairman.
Delegate Sick?
Mr. Chairman, I would like to move of the line amendments that Delegate Levine is now going to offer. To move just the line items, so we can talk about how the bill will be in that posture.
So I would
He's gonna give
change in 37, I would change a patient to his or her patient. Change A to his or her. Oh, change to his, that's fine, his. Change A to his.
Sheer.
And then I would change a good faith to an.
To what, I'm sorry?
An estimate. So it would read, shall provide upon request of his patient, comma, an estimate. And I think that would deal with the problem of it not being your patient, and it would also conform estimate to the words in the hospital setting. It would get rid of the good faith. I would ask for the line.
You just want to move them,
Yep.
see if we approve the line amendments before we talk about the.
Absolutely.
Okay.
All right, that's been moved and seconded, those line movements, without objection. All right, everybody understands that, all right. Any further questions of the patron?
I would like to address some of the issues
Please.
that were raised. I agree with Delegate Robinson that when someone has insurance, we should give them the insurance cost. That's the way I would prefer to do it. That's the way my original bill did that. It met some complications with some folks in back. I still want to work to do that. But in the event we don't have that, which I agree is the best solution, giving someone an estimate of the cost ahead of time is, I think, only fair, because we have 60+% of people bankrupt in America because of healthcare costs. They go in, they think it's an ordinary visit, and boom, $30,000 for something that they had no idea was going to cost that much. That's just not fair. When I buy something, anything that helps healthcare, I get to know the costs on the front end. And even if it's complex, even if it's a mechanic to my car, that's really complex stuff, they will tell me, you know, your Weeble fixer's broken. I don't know what a Weeble fixer is, but they will tell me the cost before and if I don't want it, I'll tell them, sorry, I'm not willing to pay that much, and I'll go to a different time. I realize this is complicated. I look at this from the perspective, I admit, of the consumer, of the patient. because the doctors, the physicians, the pharmacies, the hospitals, they are all far more sophisticated. The insurance, the pharmacy benefit managers, the people who are the least knowledgeable are the people using the system. And this thing is bankrupting people. And I don't think it's too much to ask a doctor to give an estimate of the charges. I think most good doctors do already.
All right, Doug, piece, you other questions or?
Just an observation. I do appreciate the delegate's attempts here with transparency and what he's putting forward here in this expanded bill. I'm looking at this from sort of a macro policy and sort of a philosophical perspective. You know, in law has become more of a business and less of a profession. Healthcare is not a commodity, right? It's not a good in a sense. It's a professional service. It's an environment where we want doctors and their patients to have protected relationships so that we get good outcomes, that there's quality, that there's value. This is not like parts and labor at the mechanic. And I don't want there to be a race to the bottom either. You know, at some point, there are gonna be professionals out there who are doctors, not this good doctor, or Dr. Robinson, but like in the legal profession, with all, you know, all candor, there are a lot of lawyers out there that are given pretty low ball prices, and my grandmother used to say, you get what you pay for. So I'm really concerned about kind of how we balance this need for transparency and consumer protection and those elements in a business marketplace. But knowing that this is a professional service, that we leave people's lives, in people's hands, and we wanna make sure that we're gonna get the highest and best from people in the community. So it's really just more my observation. I'm not prepared to support the bill as it is.
All right.
Mr. Chairman, are the loan amendments properly before?
Yes, ma'am.
Then, I move to report with Crawford.
It's the time.
Move to report.
Second. Didn't speak to it. That's just quickly that, I think this now is really the same thing tell me if I'm wrong, same thing we did for the hospitals, just for a doctor office visit. And this is something I would do without this legislation. Anyway, I mean, I would ask this anyway, but now, maybe they would know, they might have to answer. So.
Substitute motion, Mr. Chairman.
Yes, sir.
To lay it on the table and speak to that motion.
Second.
Yes, sir.
Ultimately, it's difficult for the providers actually to give the cost, because it's ultimately the plans that dictate those costs. So you're actually putting a burden on providers to be able to try to queue the insurance, to figure out what's going on, which changes their workflow, costs, and so forth. And it would be virtually impossible in this setting, especially an office-based setting like this, to give those costs, because it's ultimately the plans that dictate the cost. So whether you give them $1,000 price or a $5,000 price, that plan, no matter where they go, is still gonna dictate that cost.
Mr. Chairman.
All right.
Can I address what you just said?
No, he addressed it, I think you shouldn't actually address that, you should address it before you made the motion, and I apologize.
I'm
for
sorry,
that. So I tell you
Mr.
what,
Chairman.
I'm gonna give you the leeway because I gave him and I'll grant you.
Well, the doctor's offices know which plans that they're members of. So they can look up what the reimbursement will be with their plan.
That sounds
Good. Well, all right, that's good enough for discussion.
Okay.
All right, fine. We have before us a motion to lay on the table House Bill 2427 and it's been amended and substituted. The members of vote on electronic voting, the motion to lay on the table. And the motion to lay on the table fails on a 5-5 vote. So that brings us back to the original motion, which is to report
As amended.
as amended, House Bill 2427. So the members would vote on that motion.
Now the screen is dead.
I move just to flip the vote.
If this passes, you have to put me.
Maybe or maybe not.
You got it, I promise. Good deal. You did all in all, it's gonna be the same 5 votes.
All right, so the motion to report fails on a 5-5 Good, so, Delegate,
Well-
thank you very much. We gotta move on, because
All
we've
right.
had a lot of
Thank
folks
you,
over
everyone, for
3
your
hours.
time and for the debate.
Yep,
I appreciate
Delegate
it.
Edmonds, you are next in the queue, and I draw the committee's attention to House Bill 2731. Good evening, sir.
Good evening. I know you all are tired. It's been a long day, but
Frank, and your-
that's right.
Do we have an amendment or substitute?
I can't see it.
There is a substitute.
That was totally
Alright, let's get that before us.
Thank you for working. Hey?
For no reason. It's like, look at this thing. Look at that thing.
We'll pass it all on.
You don't know if that's that bill.
My bill is a lawyer type bill. It's a lawyer type bill. It's my request, that part is going to
All right, hang on, does everybody understand? The substitute's actually very substantively different than what is in current code and what the gentleman had in, so let me let y'all just quickly look at that. In current code, basically, physicians have got to provide what was before us for the patient, this disclaimer about the Lyme's test has a low sensitivity and specificity. This language now says that the laboratories that do the test have to provide such notes, so I think that's substantively different, but everybody understand what it does? Need a motion to put it properly in order?
So moved.
All right, moved and second, and without objection. All right, Delegate, tell us why we need your bill and what it does, please, sir.
Mr. Chairman, if you will remember when, I guess, former Congressman Comstock had put this bill at the time she was Delegate Comstock, had this bill, to just basically let patients know that, hey, when you get a negative Lyme disease test result, the test is not very good, and it's up to you to follow Lyme disease protocol. And that bill sunsetted a couple of years ago, and in my area, and I'm sure a lot of the rest of the state, Lyme disease is very prevalent. And so I wanted to bring back the bill. And I was working with the medical society. They suggested, and I don't care if it's on the front end, on the back end, if the doctor's doing it, or the doctor's doing it. I just wanted someone to tell the patient, hey, when you get a negative Lyme disease test result, the test is not very good, and you need to know that. Just that's basically what the bill does, and I'm sure I didn't explain that very well, but that's what the bill does. Good job.
All right. Question of the Delegate Price, yes, ma'am.
So if the lab, Mr. Chair, if the lab were to alert the patient, then the patient still has to then contact the healthcare provider.
Well, yeah.
Looking at line 18, they're encouraged to
substitute
discuss.
does not have lines on it. Sorry.
So Delegate Edmonds, Delegate Price, there is no requirement that the laboratory inform the patient at all. The requirement is that the laboratory would report to the healthcare provider on line 14, or report to the healthcare provider that the sensitivity means how many false negatives a test would have, and specificity means how many false positives it would have. And you want that to be really, really high. You want to have very, very few negative tests, and if it says it's positive, it's positive. If it says it's negative, it's negative. The challenge with Lyme, the serology and testing for that is its sensitivity and specificity is not close to 100%. Former Delegate Comstock wanted to do is acknowledge that reality in areas that Lyme disease is endemic, particularly up in northern Virginia, because the white-footed mice that are vectors carrying the Borrelia bacteria.
Most of those rich.
They wanted to acknowledge that in the code that the provider had a duty to inform his patient that the test may not be, if it says it's negative, it may not necessarily be negative. It doesn't have a really high sensitivity. What the substitute basically does is it says the laboratory that's doing the testing for the Borrelia has a duty to inform the healthcare provider that the test has a certain sensitivity, and it may not be sensitive enough. I'm pretty sure all healthcare providers already know that, but.
And it says it's encouraged, Mr. Chairman.
I'm
to
just,
talk to-
Delegate, I'm just not sure this gets you what you told us that you wanted, which is the patient be informed that it has a very low
That's where
sensitivity.
I'm losing confidence.
Yeah.
And if I may, and this may be a question for staff, I believe we did something, a notification like this, was it mammograms? Yeah, dense breast tissue, I believe. So I think it was very similar where, we've already done this. So, okay.
All right, yes, sir. Yes, ma'am, I'm sorry. Delegate Price, you've been very verbose about.
I know, I'm so, yes, catching you off guard with this. I recognize how endemic Lyme disease is all across Virginia in my region. as well. So I think it is very important that patients are informed, and kind of echoing what I've heard, but want to just raise the concern that I think that it's important information that patients are aware that a negative or a positive test for that matter may not be completely accurate, and they may want to continue to monitor their symptoms. But my concern would be, you know, in the last few times I've had blood work, I don't know that I've ever actually seen the correspondence from the lab. I either get a call from the doctor to say whether everything's okay or whether something's unusual, or they might upload the tests into the online portal that you can go in and see your blood work, but it's not a document necessarily coming from the lab. So my concern would be that you're informing the healthcare provider, who theoretically, to your point, Mr. Chairman, already knows the information, and that the patient isn't actually required to get the information. I would want to make sure that the patient is receiving the information.
And having said what delegate to that point, and delegate to that point, having said what I just said, there's nothing wrong with having another checks and balances so the providers actually get yet another piece of information from the lab. That will trigger that thought process to have a conversation. So to that point. You good?
Well, you know, you do bring a good point, and I think as long, in my view, as long as the patient is aware that the test may or may not be accurate, just so they can then talk to their healthcare provider. I guess I was under the impression that there would be a little disclaimer note, so to speak. The lab result, when the lab result came back to you at the back end versus the front end.
All right.
Apparently, this bill does not do that.
All right. Thank you. Any more questions? Anyone in the audience to speak in favor of 2731 as substituted? Yes, sir.
Mr. Chairman, I appreciate Delegate Edmonds working with us on this. When this bill passed some years ago, it was 5 years that providers were required to give notice to the patient. And I don't know of any statistics that showed that that actually helped inform anybody or not. Looking at this issue again, our physicians are not interested in having to chase another piece of paper to give to a patient. They'd rather have a conversation with them. And we come up with the idea that if this notice is put on the lab results, whether it's coming back to the patient through a portal that can be uploaded on a notice or a message, or whether it's coming to the physician and the physician's talking to the patient, this would operate as a reminder to the physician, have the conversation. That's really the most beneficial thing. I would mention, Mr. Chairman, I think this needs to be written in Title 32 and not 59, because labs are not regulated by the Board of Medicine, and that would need to be over in 32. But that was our request. We just wanted to be responsive and make sure we have good patient communication, but not impose upon physicians another piece of paper to hand out that is like a loan closing. You don't read your piece of paper, you listen to your doctor. So I just ask you to support.
All right, sir. Thank you very much. Anyone else in support of 2731? Anyone in the audience in opposition to House Bill 2731? Members understand it? Good. Like it, not like it? Need a motion of some sort? Yes, Kelly?
And I'm so sorry to be dense at this late in the evening, but I understand what you said from the lab to the doctor, but just line 17 is what's confusing me. It says a patient is encouraged to discuss it. So we've addressed the lab talking to the doctor, but then we just encourage the conversation. Is it because we don't want to legislate a mandate? And I'm not looking for the pamphlet. I am looking for the conversation. It just seems like we go weak on the patient actually getting notified with the encouragement, but we're making sure that the lab has to tell the doctor that already knows.
So I guess to that point, Scott, correct me if I'm wrong, but you know, I have a duty as a physician. If I get a laboratory test that's abnormal or that's a scans and so on, I have a duty to you to inform you of that. If I don't, you have a cause of action against me if in fact you're anemic, I don't tell you you're anemic, your anemia then causes you to have a stroke or some other problem, I got a problem. Am I correct with that?
Yes, sir.
But I guess my
Dr. Jones?
I guess my question would not be so much as the result, as we're talking about the accuracy of the test. Are you required at this point in any of the other tests that you do to disclose the accuracy of the test that you did?
Mr. Chairman, I'll respond to Delegate Price by saying the reason for the notice 7 years ago now was that Lyme disease tests were so inaccurate. And fortunately now we've got some new tests that are developed right across the street where they become more accurate as much as 80%. I shared a little clip with Delegate Edmonds from across the street at VCU where they got a new test. And so whether this notice comes to the physician to remind them to talk to the patient about the test accuracy or not, or whether it's Delegate Delaney's example of I'm looking in my portal at my lab results and I see a message that I may want to consider talking to my doctor, it's just another avenue.
Thank you.
Mr. Chairman.
Yeah, I'm sorry, Delegate Peterson.
And I think
I'm sorry.
Mr. Johnson probably will be able to know this with his vast experience in medical malpractice, legislation. Is 2021, is that standard? Why are we extending immunity to these, laboratories?
It's a holdover. When y'all imposed the notice requirement on the doctors 7 years ago, it was immunity language in there. I'm not saying that you've gotta have it in here for the lab, but that's where that came from.
All right. Delegate Robinson.
I think patients have to take on some responsibility in knowing what their insurance covers and all that kind of stuff. I mean, I'm a firm believer in that. But I have a patient portal and I don't think I've ever been out there on it. I don't take the time, I don't do it. It's my responsibility to do it. But you got someone who's 70 years old, who lives out in the country, who probably may not even have access to a portal. I think that it's an expectation that I think is kind of unreasonable, so I do think it should fall back to the doctor to make some type of contact with that patient to tell them, as you were saying.
And I was more reflecting where we were again, as Scott Johnson said, in 2013, when we passed that, the test was nowhere near, it has improved its sensitivity and specificity. All right.
But you don't see it after you're doing that test.
I think we covered all of the waterfront on this. Yes, sir.
If I may just, obviously, I'm not a lawyer, of course. I just depend on legislative services.
That's why we like you.
Hey, wow.
Rule 54.
No, I just said I'm not one. I didn't say that in like. But anyway, so my goal was just to let patients know that when you get your test and you feel like you're happy because it's a negative and you're still feeling sick, you might still have Lyme's disease. However this committee wants to go about addressing that, I think it needs to be addressed.
I agree with that. I'd be happy with any vehicle that increases the chances that people are aware of the accuracy of their test. Going back to the question of whether it needs to be through the laboratory or directly to the patient, and the question that was raised about line 17, a patient is encouraged to discuss. Would it make sense to change that to a care provider is encouraged, since they're the one reading the message, and maybe this is to serve as the reminder to the care provider, that a healthcare provider, that you might want to discuss this with your patient? If that's the audience that message is intended to reach, could that be, without it being a mandate, would that be a way to just kind of ping that care provider to say, hey, by the way, you're looking at this test result and we're reminding you, you might want to discuss this?
Mr. Chairman, if I may respond to that, if you put it in the code to say a healthcare provider has to do it and they don't, then it's negligence per se.
It is encouraged. My suggestion would just be to maintain the language as encouraged, but.
Okay, and yeah, I could live with encouraged.
And just a friendly suggestion. Smarter people than me might have a different opinion.
All right, do I have an amendment then? What would it be?
We're going to rewrite that last sentence to read something along the lines of healthcare providers are encouraged to discuss Lyme disease test results with the patient for whom the test was ordered.
All right, everybody understand that amendment?
You all know just as much as I do.
It's your bill though, but it
I'm
sounds-
happy with anything that will help the patient understand it.
It sounds like this probably is a step forward.
That's my intent,
All right.
is to help
So you're
the
good,
patient
Delegate?
get notified.
At least as you understand this evening and later, all right. All right, everybody understands it without objection?
All right, it's properly before us as amended.
All right. I need a motion. Yes, sir.
Before you-
Delegate.
I was just gonna ask a point about moving this over to Title 32, so I think Sarah's got that. Yeah, thank you.
So, you got it?
Thank you, Scott, I appreciate that, sir.
Well, we need to report as amended.
And probably moved and seconded House Bill 2731 as substituted and amended be reported. Everybody vote on the electronic voting record.
Thanks for bringing that back.
Mr. Chairman, I thank the committee at this late hour.
Absolutely, sir. The motion to report with the substitute passed on 10-0, but Sir, you do not need to be at, well, you're on, you'll be. Sure. All right, I don't see the other patrons. Delegate Sickles, did you strike your?
No, well, I'm just gonna let it go by for the week.
Gonna take it by for the day then?
No, for the week and next week too.
Why don't we take it by for the day?
Okay.
All right. Because we won't be meeting. All right, could I get a motion to take, Delegate, gentlemen, Dr. Hyde, Dr. Hyde, whatever. Delegate Sickles has House Bill 2116. He would ask for that to go by for the day.
Second.
Moved and seconded that. All right, we've got 3 bills I think left. Yours? Yeah. Delegate, hang with me, guys. Delegate Delaney, we have House Bill 2613, sir.
Okay, I'll stay in my seat.
Do you have a substitute or not?
I do not have a substitute. This is super simple. I've got a quick addition here to the existing code. All right.
Please attention to House Bill 2613.
Okay, Mr. Chairman and fellow members of the committee, in current Virginia statute, the Code of Virginia calls for health professionals delivering maternity care services to provide information about perinatal depression, shaken baby syndrome, the dangers of shaken babies, and sleep-safe environments for infants. However, those healthcare professionals are not currently required to provide information about perinatal anxiety, a symptom of which over 16% of women face postpartum, exceeding depression by over 11%. So basically, we know a lot about postpartum depression. It's incredibly important for maternal health and for the health of the family to notify new mothers about the realities of postpartum depression. What we've learned more recently since this code was written is that postpartum anxiety is also a very critical issue facing parents, new parents, and studies are showing that it may actually be facing parents at a higher rate than postpartum depression, which is obviously also a very important issue. So we're simply adding that. There is a body of best practice. A lot of organizations are already developing materials and have a lot of best practice established for education. It's just the bill simply adds that particular issue to the things that we're required to inform patients about.
Very good. Any questions of the patron? Everybody understands? All right. Is there anyone in the audience to speak in favor of House Bill 2613? Yes, ma'am.
Hi, my name
There's
is,
fine.
I've been waiting a long time. My name is Adrian Griffin. I'm with Postpartum Support Virginia. I want to thank Delegate Delaney for introducing this legislation. Believe it or not, mental health issues are the most common complication of a woman having a baby. 1 in 5 women will experience postpartum depression or anxiety. So this legislation will give us the legs to make sure that hospitals are distributing this information to new parents. And for all of you men in the audience, dads too can experience postpartum depression and anxiety at a rate of about 1 in 10. So the next thing would be to ask for funding to make sure this information is distributed.
But that is not
How
what this
that
bill
works.
does.
Is there a official impact?
That is not what this bill does.
Yeah, all right. And yes, ma'am.
Just Nicole Piper-Lauder on behalf of ACOG of Virginia. We support the bill and thank Delegate Delaney for introducing it. We have a committee opinion that does say that that anxiety, prenatal anxiety is just as important as prenatal depression or postnatal depression, excuse me, and we support the bill. Thank you.
All right.
Amy Hearns-Albert on behalf of the Virginia Academy of Pediatrics, and we support the bill as well.
All right.
Ren Rawlings, Virginia Hospital Healthcare Association, support the bill for the reasons aforementioned. Thank you.
Thank you. All right. Anyone in the audience to speak in opposition to House Bill 2613? And I do have a question. Is this going to have a, we've now added that this has to be discussed with other relevant family members. Is that going to be a
Mr. Chairman, so we're not adding that portion. Am I correct?
in line 14 that says and?
That part of the legislation is always done.
If you'd like a clarification there, are you required to disclose information regarding things like perinatal depression to those family members? That's more of a technical clarifying sort of amendment there. And also, this would not be particularly health information. This would just be general information about the incidents, things like, I assume, what to watch out for and what people can do if they seem to see some of the symptoms.
So I guess for council, so the duty going forward is to have this conversation with the mother, the father, other relevant family members or caretakers. If present, is that somewhere in here? Okay, if present. Everybody understand it's sort of, not saying good, bad, and different, I just want to make sure we all understand what we're voting on. Okay. All right, any other questions? I need a motion.
Move report.
Probably moved and seconded that House Bill 2613B requires a vote on electronic voting record. Mayor's report passes on a 10-0 vote. Thank you very much.
Thank you.
Delegate Robinson, do you have a
I do have,
bill before?
I do have a bill before.
House Bill 2563.
And I'm gonna wing this a little bit, Mr. Chairman, because I don't know where my documents are, so. And there is, two lines in it that I'll let council share with you.
Yeah. Everybody hang with us. We got some line amendments.
Two line amendments, we're going to add the same language in two places. At the end of line 28, after contains fentanyl, insert or a fentanyl analog. You're going to make that same change on the second page, line 77, change the line there as well.
Does everybody understand the amendments? All right, without objection and by general consensus. So, Delegate Robinson, tell us why we need the bill and what it does, please.
What this bill does is it will take test strips, there are test strips that are available that someone who is an addict, they wanna test their drugs, to see if heroin is laced with fentanyl, that they can actually get these test strips and use them to test. We're hoping, that there's some studies out there that this is not, we're not groundbreaking, in this area. There are some studies going on and there are places out there in Ohio and in Colorado where these test strips are available. And hopefully, if the addict is gonna say there's fentanyl in here, whether they use less of the drug or just don't use it at all, but at least they'll have an awareness of, and it's just to make them aware. There's no harm to it. I mean, other than it can cause there can be a false positive, but and so it's just kind of something else we can do in this war on drugs by making this not, contraband, something that they cannot have. That's what it does. That gives them that exemption.
All right, everybody understand? Anyone in the audience to speak in favor of House Bill 2563? Brett, you look quizzical.
No.
Anyone in the audience to speak in opposition to House Bill 2563? Are you there? You look tired. I'm not sure.
Whoever has spoken today.
There's a lot of people out there.
No, I understand. All right.
You guys don't want us to talk anymore?
All right. Measure S with us. Any further questions to that? Yes, sir. Delegate House.
No questions, just a motion.
Yes, sir.
Motion to report.
Probably move and say that House Bill 2563 as amended be reported. Members vote on electronic voting record. Right, the measure advances on a 10-0 vote. Okay, I think our last bill for this evening, we took your bill by the day. Delegate Bell, John Bell, as you all know, is still, I think, out of stage, and his LA spoke with me about, passing his bill by. I instructed him this will be our last evening, but he does have the option of taking up with Chairman Borak. I think he's probably going to be back on Monday or so. So I suggested he take it up with Delegate Orrick. John Bell has House Bill, I don't have a number here.
I think it's 2240.
Oh, so it's not our document. My apologies. All right. You know what I'm going to say. Right. I'm going to give the gavel to Chairman Peace to carry over so that I can present my bill. I think it's the last bill.
Turn your attention to Delegate Garrett, who's gonna present his legislation. You have a substitute amendment to offer, Delegate Garrett, to House Bill 2798. I do.
Wow.
Okay, well, the amendment and nature of the substitute will be distributed around the table. So doing will adopt without objection. 2798, amendment H of subject before the committee. Turn your attention to Delegate Garrett.
Thank you, Mr. Chairman. Let me just tee this up and tell you kind of what it does and why. As you all know, back in 2012, I think it was Delegate John O'Bannon introduced legislation to create the Virginia All-Payer Claims Database. It was established to facilitate this data-driven, evidence-based improvements in our access and quality and the cost of healthcare, and as well to promote and improve public health. Let me give you 3 examples of how it's been used. It's been used to track and analyze cost burdens of hospital contracted infections, because we've got a lot of folks putting a lot of data into this database, particularly for research elements, looking at diabetes, other chronic conditions at the state or local level. Been used to study opiate prescription patterns across our Commonwealth. Been used by DBHDS to study service gaps for CSBs and optimize local health networks. What we've had heretofore has been a voluntary system whereby many of the insurers have been putting their data in, state agencies have been putting their data in, other members have been able to take that data out. Last year, as you all recall, we had a mandate for the stakeholders to sit down and figure out how we can move the APCD forward. And the Virginia Association of Health Plans, Virginia Hospital Healthcare Association, Virginia Health Information, and I see Michael Lundberg in the back. And how you can stay here for 2.5 hours, sir, I don't know, but the Virginia Department of Health all sat down, and as well, I think Medical Society, other folks sort of sat down and figured out a process, which is the budget bill, which is the bill before you. So I'm going to defer to, you all know what this substitute says better than I do. I don't want to misspeak about the 5 elements that I knew what it was. So Matt, come up here and explain my bill if you would, please, sir. I don't want to speak to these 5 elements that I knew was in there, but now we have it in substitute.
Good afternoon, Mr. Chairman, Matt Cobb, Williamsville, representing VHI. I'm here to report peace in the valley on this bill. We have the health plans and the hospitals in agreement.
Wow. Standing side by side.
Standing side by side.
Where's Scott Johnson?
Right here.
Right here.
Right here. So the big issue or the big change in the bill from going to voluntary to mandatory is what the parties kind of came together with is that we would establish a data review committee for any request for data from outside of state use. So BDH, DNAS, state agencies can still access the APCD, it's still at no cost to them. But there's a data review committee process set in where folks who want to access data will come in and make a request. The data review committee would determine if it falls within the scope and the parameters and purposes of the APCD and approve it. So there's a way to track it. Those individuals would sign data use agreements and other documents to make sure the data is used only for the purpose approved. One of the other big changes that we're going for with the mandatory system is right now we have about 4.4 million lives, and I think we get up to 4 million lives, we get about 5.5, I believe that's right. By doing this, by bringing in the last of the health plans that are not voluntarily participating, and then also going after the self-funded ERISA plans. Under a Supreme Court decision, they cannot be mandated to participate, but we can voluntarily have them. So there's an opt-in process. The plans have graciously offered to help us try and get an opt-in, providing us a list of those that do and a list of the self-funded ERISA plans in Virginia. So that efforts can be made to do that. So we think we can increase the number of covered lives in it, increase the utilization of the APCD, and there is peace in the valley. We're happy to answer any questions, or they'll answer the questions. I'm done.
Next, in support, anyone else want to join with
Yeah,
Mr. Cobb?
just Virginia Hospital Healthcare Association worked on it over the summer. It is different than what you saw in the old bill. A lot of stuff added in there. The one thing I would just add on is that in going through this process, we did look at other states that have mandatory APCD and kind of mirrored the best practices from that to develop this model. Some of the goals here are transparency, not just overall goal of transparency that you get with APCD, but also transparency of the process, again, of who's requesting the data, who's using the data, and for what purposes. And we actually think that there's a big benefit of that, and that is you start realizing why people need this data, you're using it, and you can use that to then maybe possibly develop future reports and other things that will make this an even more useful tool to the Commonwealth. So fully supportive of this approach.
Anyone else in favor of this legislation?
I'm Doug Gray with Virginia Association of Health Plans.
transparency and governance changes in the bill really bring it into line with the other APCDs across the country. And it's important for the public to understand what the data is being used for, and all of the stakeholders, and how the decisions are made. And we've made a number of changes to make sure that those processes work in an effective and transparent way. And we're very happy about that. I want you to know that it was many, many meetings. And we didn't, come together on every last piece until we really it got toward the end of the deadline. And everybody gave, and in a significant way, on their concerns. I mean, the hospitals gave significantly, the health plans gave significantly, and I think BHI helped in their efforts too. So I want you to know it's a serious effort. It took a lot of effort throughout the entire year. And we're very thankful that Delegate Garrett's willing to take it up.
Is there anyone here in opposition to this legislation? Members of the committee have any questions? Delegate Hodges.
One question, if I may, and they may know the answer to this. Currently in the commercial plans and reporting your 35–40%, by including the ERISA and bringing those in and looking at other states and what they've adopted, do you know what percentage, how has that increased overall as far as percentage of claims that are being reported? I mean, was there a significant increase, or?
Yes.
This is Kyle Russell, BHI.
Yes, sir.
I don't know what the exact number would be, but it would be a significant increase, not just in the large employer risk population, but also in additional Virginia municipalities and other individuals that are commercially insured that may or may not be included now. They would be in a mandatory program, so we expect the scope for the commercial population to go away with that.
Okay. Are there additional questions, members of the committee?
What about our school systems, our school divisions?
Delegate Sigler.
Our school divisions are covered by ERISA. Do you have any, are they participating? I mean, I think Fairfax County Schools is one of the biggest employers in the state, or second biggest.
It's a case-by-case basis. Our understanding with most ABCDs is that municipalities and other sort of subsequent groups tied to those don't fall under the Supreme Court decision, so they do get pulled into the mandatory program. Right now, it's a case-by-case basis.
Before we take action, some penultimate comments. Hearing none, committee acts by motion. Our Delegate Garrett, would you like to say anything?
So I would only tell you as well, Senator Green has the identical language coming through in the other body. He was absolutely ecstatic to see these two gentlemen standing next to each other. So.
Very good. Good work, Delegate Garrett. Appreciate your leadership. Is there a motion? There's a motion to recommend reporting House Bill 2798, amendment nature substitutes for second.
Second.
Properly seconded. Discussion on the motion. Hearing none. All those in favor, cast your vote on electronic vote. Okay, please close the roll. Bill is recommended to report with substitute 10-0.
Right.
Give the gavel.
All right, hang with me, members.
I got it. Hold on.
Members, keep. So I believe that clears our docket for sub 1. I do not anticipate we will have any other bills sent down to us. As you know, our next full HWI meeting is on Tuesday. Anything with approach has got to go up there, because Tuesday afternoon I am hearing 123 budget amendments, and all of the bills have got to be cleared then. My understanding, if you have a bill before HWI, before HHR, it may well get heard Friday as well. So I will get that out to you, to the members as well. I want to thank each and every one of you. What I saw tonight is actually why prudent public policy comes out of this Commonwealth. Every one of you respectfully dealt with things, and we all have different viewpoints, and I truly respect that. You all were attentive. I think absolutely every one of us learned something tonight, and I think that is of great value. So I just want to thank you all for hanging in here for 3 hours and dealing with some pretty important things for